Welcome to our second video on pediatric musculoskeletal disorders. Let's begin. In this lecture, we'll cover the common foot deformities: clubfoot, metatarsus adductus, pes planus, and pes cavus. Clubfoot is also known as congenital talipes equinovarus. The name itself describes a condition. It is a widely common congenital deformity and occurs mostly due to the dominance of posterior tibial muscle. It can be remembered with a mnemonic Cavus of midfoot, which causes the high arch of foot; Adductus of forefoot, where toes are turned inwards; Varus of hindfoot, where heel turns inwards too; and Equinus of hindfoot, that is the abnormal plantar flexion, typically as a result of short Achilles tendon. Let's see an image of clubfoot in the next slide to make everything clear. This is a picture showing bilateral clubfoot. We can appreciate abnormal plantar flexion of foot, adduction of forefoot with the heel turning inwards. Diagnosis is usually clinical, but imaging can be considered. X-ray shows the talocalcaneal parallelism, where the long axis of talus and calcaneus bones become parallel. Management is with traditional Ponseti method, where there is serial stretching and manipulation followed by casting to bring back the foot to its normal shape and position. Surgery is considered if this method fails, and is usually performed within 3 to 6 months of age. Next, it's metatarsal adductus. It is adduction of the forefoot with convex lateral border and concave medial border. Notably, hindfoot is in neutral position. This deformity is mostly seen in firstborn infants and can be associated with hip dysplasia. It causes in-toeing in children. In-toeing means that when the child runs or walks, their foot turns inwards. Etiology is unclear and is believed to be due to imbalance between the muscles of leg and foot. Here is the image of metatarsus adductus of foot compared with normal foot. Please note how the forefoot is adducted with convex lateral border and concave medial border. Diagnosis is typically clinical. Thus, imaging is usually not required. Management is usually not necessary, as metatarsus adductus mostly undergoes spontaneous resolution. However, corrective shoes or cast can be used for special cases. Now let's move on to pes planus. Pes planus is also known as flatfoot, where there is loss of the medial longitudinal arch of foot. Etiology can be congenital, presenting as isolated condition or associated with other neurologic conditions. However, pes planus can also be functional and occurs due to dysfunction of posterior tibial tendon or trauma, for example. Flatfoot is of two types, rigid and flexible. In the flexible type, the medial longitudinal arch is intact when heel is elevated or when the patient is not bearing weight. On the other hand, the rigid type is characterized by the persistence of arch absence during weight bearing and heel elevation. Here in the left picture, we can't appreciate the gap between the plantar foot and the surface on which the patient is standing. This is a case of flat foot, also known as pes planus, where there is loss of longitudinal arch of foot. Diagnosis is mainly based on physical examination. Lateral foot X-ray is only needed if the condition is painful or of rigid type. X-ray shows parallel tibial and talar axis. Management involves serial casting after birth. Surgery is considered only in case of failure. Let's shift gear to pes cavus. Pes cavus is also known as high-arched foot, characterized by high longitudinal plantar arch of foot. It is mostly idiopathic. However, it can be associated with neurological and muscular disorders or Charcot-Marie tooth disease. It is believed to be due to imbalance between strong plantar flexion and weak dorsiflexion, resulting in this typical presentation. This is a picture showing high-arched foot, also known as pes cavus. Please note the high longitudinal arch. Diagnosis is mainly clinical, but X-ray of foot and ankle joint can be considered. Management includes wearing corrective shoes and undergoing physiotherapy. Surgery is reserved for cases of resistant pes cavus. Surgery includes osteotomy and release of plantar fascia. A 3-month-old boy is brought to the physician by his parents due to deformed foot. The physical exam reveals adduction of the forefoot with convex lateral border and concave medial border. The hindfoot is in neutral position. What is the most likely prognosis of this patient's condition? This 3-month-old boy presents with deformed foot. Physical exam reveals adduction of the forefoot with convex lateral border and concave medial border. The hindfoot is in neutral position. This is a classic description of metatarsus adductus. Metatarsus adductus resolves spontaneously most of the time. Corrective shoes or cast may be needed for resistant cases. A 6-month-old baby girl is brought to the pediatrician's office due to a deformity in both of her feet. On physical exam, the physician notices that the posterior tibial muscles of the child appear larger compared to the other muscles. On X-ray of the child's feet, the long axis of the talus and calcaneus bones are parallel. Based on this child's diagnosis, which additional feature would be expected on physical exam of the child's feet? A. Normal plantar flexion. B. Toes turned outwards. C. High arch. Or D. Heel turned outwards. This 6-month-old baby girl presents with a deformity of both feet. It is noticed that the child's posterior tibial muscles are dominant. On X-ray, talocalcaneal parallelism is noted. Based on these features, it should be clear that the child most likely has a club foot deformity. The features of club foot can be remembered by the mnemonic CAVE. This stands for Cavus of midfoot, which causes a high arch. Adductus of forefoot, where toes are turned inwards. Varus of hindfoot, where heels turn inward, and Equinus of hindfoot, which is abnormal plantar flexion. On physical exam of this child, a high arch would be expected, thus making answer choice C correct. Here's a slide reminding us of clubfoot. Answer choices A, B, and D are all incorrect because they represent the opposite of what would be expected in a clubfoot deformity. And that concludes this section.